Recording in progress.
There will now be a moment for silent prayer or meditation. Please take your seats. Thank you very much.
Chair, it looks like there is no quorum here.
I would like to remind honorable delegates that the rules, in particular sub-rule 21, 22, and 23 of Rule 103 shall apply in the sitting. In accordance with the Council Rule 229, sub-rule 1, there will be no notices of motion or motions without notice. Honorable delegates, before we proceed to questions, I would like to take this opportunity and welcome Honorable Motswaledi from the Social Service Cluster, as well as all permanent delegates, the MECs, and all special delegates and SALGA representatives to the House. Honorable delegates, kindly be reminded of the apology of the Minister of Social Development due to an official commitment abroad. The questions to the Minister are therefore deferred to the next determined sitting. I would like to remind delegates that in terms of Rule 229 of the Council rules, the time for reply by the Minister to a question is 5 minutes. Only 4 supplementary questions are allowed per question. A member who has asked the initial question would be the first to be afforded an opportunity to ask a supplementary question. The time for asking a supplementary question is only 2 minutes. And the time for reply to that supplementary question by the Minister is 4 minutes. The supplementary question must emanate from the initial question that was asked. Having said that, I now take this opportunity and invite Minister Motswaledi to the podium to respond to question number 37 as asked by Honorable Finis. Over to you, Minister.
Thank you, Chairperson, and honorable members of the House. The relationship between the recently launched program targeting 1.1 million persons who are HIV positive directly links to the 95-95-95 targets that were adopted by the United Nations Program on HIV and AIDS. Honorable members, back in 2014, at the International Conference of AIDS, International AIDS Conference held in Melbourne, in Australia, the UN AIDS, the structure that is tasked by United Nations to deal with HIV and AIDS, came up with a concept called 90-90-90. In June 2021, this concept was upgraded to 95-95-95. What it simply meant is that if in any particular country or any particular village or setting, if 95% of the people who are HIV positive know their status, that is the first 95. The second 95 is if those who tested HIV positive, 95% of them are put on ARVs. That constitutes the second 95. The third 95 is if those who are on ARVs, at least 95% of them get virally suppressed, then you have arrived. Because when you are virally suppressed, it means the virus cannot be detected in your bloodstream when you measure it. You are still HIV positive, but you can't detect the virus in your blood. If it can't be detected, then it can be transmitted from one person to the other, and transmission stops. When a country has arrived there, the country can justifiably claim that they have eliminated HIV/AIDS as a public health threat. We have not eradicated it, but we have eliminated it because we no longer have a spread from one person to the other. It stops with the people that's having. Now, in South Africa, we are at 96, 79, 94, meaning on the first 95, we have exceeded our targets. We have overperformed. But on the second 95, we are at 79%, which generally is low. I know it's 1% short of 80. But in terms of 95, we are not there. On the third 95, viral suppression, we are at 94%. Now, according to our calculation, to move the 79, the middle 95, which is at 79, to move it to 95, you need 1.1 million people. And this 1.1 million people are people who have tested. We know they are there, they are positive. Either they were on treatment before and stopped, or they've never started treatment. Our job is to look for them and put them on ARVs. Then we'll have reached our 95. In terms of the numbers, Honorable Member, we even know where they are. In the Eastern Cape, there are 148,000, Free State 22, Gauteng 326, KwaZulu-Natal 117, Limpopo 180,000, Mpumalanga 134, Northwest 53,000, Northern Cape 17,000, Western Cape 163,000. So each province is not looking for 1.1 million. They are looking for these thousands I've mentioned. We've even divided them into districts. We know each of the districts in the country, how many are the 1.1 million people, out of that 1.1 million people are looking for. We've even divided it into facilities, that this clinic, people who are attached to it are so many. So you may find that the figure of 1.5 million is scary, but you may find that the clinic has to look for only 5 people. And that's how we've divided it right up to the bottom. And we are confident that by December we'll have reached this. The question is, how is the PEPFAR funding affecting it? It will affect the staffing, honorable members, as we have said. South Africa is buying its own ARVs. We are not using PEPFAR money to buy ARVs. 90% of our ARVs, we buy them with our own money from our own fiscus. The other 10% is bought by Global Fund, which has got no links to PEPFAR because Global Fund is based in Geneva. It's all countries who came together 20 years ago to put together money to fight TB, malaria, and HIV and AIDS. Thank you very much.
Thank you very much, Honourable Minister. The supplementary question is going to be asked by Honourable Feni. Honourable Feni has since apologized for today's sitting. Over to you, Honourable Feni.
Thank you very much, Honourable Chair. Thank you very much, Honourable Minister. In fact, also thanking the response that you've made. It is clear that South Africa has a clear and effective program for monitoring and treating people living with HIV. How do we compare with other countries in Africa and the rest of the world?
Thank you very much. Over to you, Minister.
Well, the bad news is we've got the biggest load of HIV and AIDS in the whole world. It's the biggest. It's estimated by UNAIDS that South Africa has got 7.8 million people who are HIV positive. The good news is that the program we have started in 2010 of HIV counseling, testing, and treatment is also the biggest in the world. At the moment, we have got 5.5 million people who are on ARVs. That's by far the biggest because we have got the biggest load. Now, we are saying, even if we have got the highest number of people on HIV and AIDS, but in terms of the 95 targets, we are still short of 1.1 million. That's why on the 25th of January, we went to launch this project at Kisane Baragwanath Hospital and Lillian Ngoyi Community Health Center in Soweto. We went there on the 25th of February. We launched this program. We are busy now, as I'm saying, looking for these people. The advantage we have got, fortunately, over many of our compatriots on the African continent is that PEPFAR is funding us only in 27 out of 52 districts. And in that 27 districts, the number of workers who are there are 271,606. PEPFAR is funding only 15,000 of them. This is an advantage because, unfortunately, because of small economies on our continent, some countries have got their total health budget, most of it being funded by American, US aid or PEPFAR. There are countries on the continent, very unfortunately, where you find that 60% of their total health budget, not even HIV and AIDS, the total health budget is funded from the US. And when that funding is cut, it's really trouble. So at the moment, we still have got that advantage that, for instance, we are not going to stop taking ARVs because of this cutting, because ARVs come from our own fiscus. Thank you very much.
Thank you very much, Minister. I'm now inviting Honorable Du Plessis to ask the follow-up question to the Minister.
Thank you, Honourable House Chair. Honourable Minister, there is still an impact with regards to PrEP and US aid. However, were any contingencies put in place as part of due diligence, risk mitigation, and analysis for the funding, or was it seen as a given without any forethought of geopolitics? Thank you.
Over to you, Minister.
Honourable Member, there is a question about that, which I'm going to ask very thoroughly. You just asked it before. It's one of the 6 questions I must answer today. We do have a thorough analysis of what's happening with PEPFAR funding. As I said, South Africa has got 9 provinces with 52 districts. Out of these 9 provinces and 52 districts, PEPFAR is only found in 27 of the districts. They chose the 27 because they are high burden districts. In other words, they are carrying a particular high burden of HIV/AIDS with the criteria used by PEPFAR. Now, it so happened that in the Northern Cape, not a single district qualified for that high burden status, not that there's no HIV/AIDS there. So PEPFAR then is only in 8 districts. That excludes Northern Cape altogether. Now, in the 8 districts, we know that 7 are in KZN. Out of the 11 districts, 7 are PEPFAR districts. The second biggest is Eastern Cape. Out of their 7 districts, 5 are PEPFAR districts. The third is Gauteng. Out of the 5 districts in Gauteng, 4 are PEPFAR districts. Unfortunately, it includes all the metros. Then we go to Northwest and Mpumalanga. Each one of them have got 4 districts and 3 are PEPFAR. Then you go to Limpopo and Free State. Limpopo has got 5 districts and 2 of them are PEPFAR, same as Free State. In the Northern Western Cape here where we are, it's only 1 district, which is PEPFAR. Unfortunately, it is the metro itself, which is 60% of the whole total population of the province. Now, in all those districts, there are 271,000 people, 606, who every day wake up to work on HIV/AIDS, be they doctors, nurses, counselors, social workers, field workers, is 271,606. But 256,154 are paid for from our own fiscus. That remains with 15,154. These are the people of consent. But even them, the ARVs they are using are bought by our own government. Only that they are paid for by PEPFAR, and their PEPFAR is also paying for their logistics, like transport, etc., etc. So we actually know who is affected and who is not affected. And I'm repeating, our saving grace was that right from the beginning, we have never depended on PEPFAR to buy ARVs for us. We have actually dependent on them, on the people hired and the logistics. And some of these people who are hired are researchers in universities. They are doing research. The PEPFAR is funding 39 NGOs who have got a total of 150 who are attached to the 39. I mean, sorry, let me put it differently. There are 150 NGOs who depend on PEPFAR in the country. 39 are what we call principal recipients, and the rest are subcontracted to the 39. That's where the problem is, and some of them are in universities. They are doing research. In other words, they are not patient-facing directly. They are doing research about the pandemic. And that is the problem that we are trying to solve. Thank you.
Thank you very much, Minister. The next follow-up question shall be asked by Honorable Ngcobo.
Thank you, House Chair. Honorable Minister, given the substantial commitments for this campaign, could you provide measurable benchmarks for assessing its success beyond treatment enrollment numbers? How will the department ensure this initiative leads to sustained viral suppression and a meaningful public health impact rather than becoming a short-term intervention? Thank you.
Sorry, Chair, are you talking about the overall campaign or the 1.1 million? I'm not very clear about that.
Overall, Minister.
Yes, the overall campaign, as we said, since 2010, when we launched it, is huge, I'm telling you. It has got 5.5 million people. And we know, the reason that we know that we are at 96, 79, 94, is because we have got measuring instruments done by our scientists, done by UNAIDS, done by the World Health Organization. They know exactly what is happening in every country. We know who our clients are, and we've even divided them into groups. For instance, if you have got 5.5 million people going to our clinics every month, that's going to be a complete disaster of overcrowding. We already have overcrowding in our clinics, but just imagine if we add 5.5 million people. So what we have done, we've come up with a program called CCMDD, meaning Central Chronic Medication Dispensing and Distribution Program, whereby people who are stable, we even know who is stable. How do we know? Because doctors tell us that this person is stable, all they are coming for is to collect their treatment. So we put CCMDD for them. We said, if you are stable, then you don't have to come to the clinic every month. Give us the address where we'll go and deliver your ARVs. And people have done so. We take that list. We have got 2 service providers in that regard. We give them the list and we give them the ARVs. In other words, we give them the what you call, the letters from doctors, the prescription, I mean to say, you give them the prescription, they look at it, they take the ARVs, they package them for each individual, and they label the package and they carry it and go to deliver it. If the person chose the very clinic where they are collecting, then they'll still go to the clinic, but they are not going to queue. They go straight to the dispensary, they found their package there, they take it and go away. If they choose any other venue, we'll still deliver there. Secondly, we said maybe it's not even helpful for people in terms of transport money to come every month to collect that, whether they collect a clinic or royal family or whatever address they've chosen. Then we came with what you call 3 months, multi-month dispensing, or 3 MMD, where a person gets a supply for 3 months at a time. In December, during the International AIDS Conference held in Gqeberha, with the deputy president, there are people who marched and say they want 6 MMD. That means they want us to supply them with ARVs for 6 months. We have agreed because all the statistics and experience shows that it works very well, and we are going to do that. So all those programs, we are doing them in order to be able to manage this program. Thank you very much.
Thank you. Thank you very much, Minister. The next follow-up question is asked by Honorable Siwisa.
Thank you, Chair. Greetings, Minister. Minister, given that this country has the highest number of people living with HIV, and for the past couple of years, the health budget has suffered severe cuts and austerity measures implemented by the National Treasury, weakening the country's ability to fund its own healthcare system. What measures have you put in place to ensure that the little funds that are allocated are managed effectively and not misused by the ruling party, so that all South Africans can have a chance to access to quality medical services? Thank you.
Over to you, Minister.
We have never suffered at any stage the problem of being short of ARVs because of austerity or budget cuts or because of whatever. We've always managed these funds very frugally in such a manner that we always, as I'm standing here in front of you, the total amount of money we spend for HIV and AIDS in South Africa is 46.8 billion rand. Out of that, 74% comes from our own fiscus, 2% only comes from the private sector, people who are on medical aids or who are working for companies that decided to provide them ARVs. They contribute only 2%. That gives us 76% coming from here. And then we remain with 24%. Out of that 24%, 17% is from PEPFAR. The remaining is from Global Fund. They've got their own mechanism to follow up this money. I don't think there's any report that you ever got from the Auditor General or whoever who complained about corruption and disappearance of money in our HIV/AIDS program. It has never happened. At least I've never heard about it. Thank you.
Thank you very much, Minister. We're now moving to the next question, which is question 49. It's been asked by Honorable Du Plessis. Over to you, Minister.
The question is about mental health. What measures are in place to improve mental health in South Africa? The Department of Health is making progress to improve mental health in our country. South Africa is one of the few countries that are within the World Health Organization recommended percentage bracket of the overall health budget. That means the World Organization has recommended that you spend 5 to 10% of your overall budget on mental health. We are one of the few countries that are doing so. One of the key objectives of Mental Health Act 2002, Act number 17 of 2002, is to integrate provision of mental health care services into general health service environment through the pursuit of this objective. One, we facilitate that comorbid occurrence of mental and physical illness be better managed. We are also attaching mental health units to general hospital using the mental health infrastructure guidelines that was adopted in June 2014. We are also, number 3, strengthening and continue to strengthen training of healthcare providers. We have started the project of training traditional health practitioners on basics of mental health information. As we know that in our African culture, people usually approach them first when they experience mental health symptoms. 406 traditional practitioners in 7 of the 9 provinces have already been trained so far. We increase and are continue to increase the number of mental health care providers at primary health care level. We continually use various platforms to educate the public on mental health issues, including its risk factors like substance abuse, which is emerging to be one of the biggest contributors of mental health. Early signs, as well as where to go if someone thinks their loved ones have signs of mental health problems. The National Mental Health Policy Framework and Strategic Plan 2023 to 2030 was adopted following the review and update of the mental health policy. The Ministerial Advisory Committee on Mental Health is in place as appointed in May 2022 for a 5-year period. This committee that comprise of experts in the area of mental health, have representatives from stakeholder departments, representatives from non-profit organizations that work in the area of mental health, and representatives of mental health care users. That has been critical in providing the necessary technical advice to the department in the area of mental health. While progress has been made, there remain much more to be achieved. We look forward to this program being more resourced in future, such that its budget moves closer to the upper value of the WHO funding norm of between 5 and 10% of the total health budget. Thank you very much.
Thank you very much, Minister. Is there a supplementary question, Honorable Duplessis? Over to you.
Thank you, Honourable House Chair. Thank you, Honourable Minister. And yes, it is definitely a justifiable spend. However, when you look at South Africa, we are third highest in suicide rate in Africa. We also recently had various pictures of patients, and we will forward it to you, who were psychiatric patients who were tied up in the waiting with not acceptable procedures, basically with handcuffs in the waiting area. So what is the money spent on for mental health? You gave a full report. However, if I look at other countries, developing countries, and they are spending much less on mental health, I'm not advocating for less spend. I just want to know what money is spent on if other developing countries are spending 0.5% and their suicide rate is exponentially lower than in South Africa.
Minister, over to you.
Yeah, Honorable Member, unfortunately, suicide rate is not directly linked to mental health. There are many other factors that can drive people to suicide. Many, apart from mental health. There are totally normal people who have never gone anywhere near a psychologist or a psychiatrist whatsoever, who are very normal, but the following day you find them gone. And it's quite unfortunate. We are spending this money on mental health processes. The problem we are faced with many other countries are faced with, that's why WHO came with these figures, is that in any country in the world, they've discovered that mental health comes at the back of the queue all the time, unfortunately. That's why they give us this figure, and we are trying to reach it. But as we are saying, the amount of mental health problems in our country have escalated so much that the figure looks very insignificant, looking at the number of people. For instance, when you come to mental health practitioners, 80% of them are in the private sector, dealing with very few people who happen to be on medical aids, who only constitute 14% of the population. The whole 86% of the population is served by a very small number. We also have got very few mental health facilities. You may have heard when the president announced among the hospitals that we are going to build, that there's going to be one mental health hospital. That mental health hospital is going to be in Mpumalanga because the whole province doesn't even have a single mental health institution to their name. And so those are some of the things that we're going to use the money for. The issue of tying people in the waiting area, Honorable Member, unfortunately, very unfortunately, is happening. If you were to meet a person who is on crystal meth, a person who's on a drug called Mr. Crystal Meth, a street drug, you'll understand why they are tied in chains. They are very, very, very violent, extremely violent. And they just go, you might have heard stories about a patient who was killed in Philadelphia hospital 2 weeks ago. That patient who killed a patient was on crystal meth. He's in jail now. He was so wild, which unfortunately, even security people were running away from the violence that they've seen there. That person was on crystal meth. There's no way you can't put them in chains. Because if you don't put them in chains, there's going to be havoc. In fact, we are faced with a new crisis, where after stabilizing them, when the hospital discharge them, Families refuse to take them. Their own children, they say, no, please, let the state see what you can do. We don't have the capacity to deal with this person because they've seen that violence. So there is no way that you can't put them in chains. I personally have been assaulted by mental users 2 times in my life as a doctor, but it was nothing compared to what people are seeing now with crystal meth. It's just something that we don't want to see happening, but unfortunately it's happening. So it's quite unfortunate that they have to be in chains. Even this one who killed was put in chains. When I arrived in the hospital that afternoon, they have to put him in chains because even armed security people were not very, confident to go next to him. That's the level of violence that you see with this. And unfortunately, quite a large number of mental health people who arrive in our hospital on Fridays are now people who are on crystal meth. Thank you.
The next follow-up question will be asked by Honorable Mokweli.
Thanks very much, Tulo. Honorable members in the August House, Tona Yachaupelo, ke le dumedishe be ke la mogele ka mo ntlong e ya the Council of Provinces. Tona ke rata ho dumellana le lena gore ke nnete Afrika Borwa ke e nngwe ya dinaga tse le gore mokgatlo wa lefatshe wa tsa maphelo o bontshitse gore o shumisha tekanyetso ye le gore ba e beile.
Honorable Mokweli, can you hold on? Can you please mute the person on the virtual platform? Thank you very much.
Ke a leboha,
Over to you. Sorry for disruption.
Be ke rata ho dumellana le lena gore ke nnete mokgatlo wa tsa maphelo wa lefatshe o bontse gore Afrika Borwa ke e nngwe ya dinaga tse le gore di shumisha tekanyetso ya tsona kudu mo tabeng e ya bolwetse wa monagano. But Tona go na le bothata bo bogologolo mo boleng gona mo tabeng tse kudu ka taba e ya taba e la ka lentswe la seeng re bitsa gore ke stigmatization of the thing of mental health. Be ke nyaka go tseba mo lena Tona gore na ke leano le lefeng le go department or kgoro ya lena e na go lona go shogana le taba ya gore ge motho a na le bolwetse ba tsa monagano go be le taba ya dipolelo tse di seng gona. Ke a leboga.
Over to you, Minister.
Yes, thank you. We are trying our best to educate our people. You will understand that we have got a very huge experience about the issues of stigmatization, because it's also there in HIV and AIDS, even in TB. Then you have got it in mental health. So we share those experiences to try and educate our communities. Remember, in the communities, mental health is usually related to even things that we are not able to talk about here, about what the person did to be mentally ill and all that. So all those are societal things. As I have said, we have even moved into communities to try and educate, even to train traditional health practitioners. Who are the people who will go to them and start recognizing mental health instead of diagnosing many other things which lead to the death of people because of stigma. So it's an ongoing program. We want you, even you, as members of this August House, in your constituencies to talk about these things so that people should know and not stigmatize people with mental health. When I grew up, even when I ran a practice in the rural area, once you have got a mental health problem, people bring you forward and say, you now belong to GG. GG. It's because there were provincial governments during that time. There was a key provincial government, Transvaal, Free State, Natal, and then the national government was called General Government, GG. So when people say you belong to GG, they believe once you have got mental health, leave the family, leave the village. That's why the World Health Organization passed a resolution on de-institutionalization. That is better to keep people in the communities than to put them in institutions. Unfortunately, we are failing to de-institutionalize because it needs a lot of resources in the community. You need to have committees in the community. You need to have good primary health care. I'm not sure whether you remember that the disaster that fell Gauteng, which you call Life is Dimeni, they answered by saying they were trying to de-institutionalize. But de-institutionalization is not done in a shortcut way. You need structures, you need a lot of understanding. You need to be very sophisticated before you de-institutionalize, because people don't believe it's their responsibility. I've just given you information here that we're having it very tough with the issue of crystal meth, methylamphetamine. People don't feel anybody who has taken methylamphetamine must be brought back to them, even if they are a child. They refuse them, and hospitals are in dire straits. They don't know what to do with them because they believe, in other words, the stigma you're talking about and fear is very perverse among our people. So it needs constant education. Thank you very much.
The next question is from Honorable Kennedy.
Thank you, Chairperson. Good afternoon, Minister. It is a catastrophic situation, Minister, to hear about new mothers compromising their health, their lives, and well-being of their newborns, post giving birth in public hospitals. It is further a concern that there's no mental health support made mandatory to decipher readiness of the mothers taking home with them an infant that could be put in a harmful situation to this reality. In what way, Minister, is the department improving its scope of understanding maternal mental health and to provide support to mothers faced with mental health issues during and post-pregnancy? Thank you.
Over to you, Minister.
We, Honorable Member, we understand that very, very deeply, because every health practitioner has gone through training in that regard of postpartum or puerperal. They used to call that puerperal psychosis and all that in the olden days. That pregnancy and childbirth are related to some of mental health. So many of them are picked up and screened during antenatal care. The problem we're having are the number of primary health care practitioners with mental health training. That's the biggest problem that we're having. That is why when we look at the critical skills in our country among nurses, there are 4. A theater nurse is a critical skill nurse because there are very few of them. An ICU nurse is critical skill. A high care nurse is critical skill, but a mental health nurse is also a critical skill. The unfortunate part is that these are critical skills all over the world, even in rich countries. So rich countries are just able to nab them like that in front of you, even if you are the ones who train them, because you can't compete with them about the salaries. That's where our problem is, but we understand that very well. We are even training our community health workers to catch the signs of mental health among women who have just newly delivered their babies because of knowledge of the phenomena Honorable Member has spoken about. Thank you.
Thank you very much, Minister. The last follow-up question is from Honorable Farmer.
Thank you, Chairperson. Thank you, Honorable Minister and Honorable Members. Honorable Minister, what is government doing to promote mental well-being with focus on prevention and early intervention? Thank you.
Thank you very much, Honourable Farmer. Honourable Minister, your response, please.
Yeah, thank you very much. You just have to go back to the definition of health as outlined in the Alma Ata conference that took place back in 1978, organized by the World Health Organization and UNICEF. They were worried about what we're saying about even the definition of health. And they came with a new definition of health, that health is not just the absence of disease or infirmity, but is a state of good physical, mental, and social well-being. That every health worker needs to be aware of that. That when you diagnose a person healthy, you don't just say because this person is not in bed, is not on any medication, is healthy. There might be mental problem, there might be social problems, and you combine them together. And we are trying to use those to try and prevent. Unfortunately, mental health has got numerous causes. We know, for instance, what causes diabetes, cancer, and all that. Mental health, it can be anything in the environment, in the social environment, in the psychological environment, in the spiritual environment. So it's quite a lot of numerous things, but we try our best that we must educate our people. That's why I said we are spreading community health workers all over the country to spread the words of prevention of diseases and promotion of health. Thank you very much.
Thank you very much, Minister. That concludes the responses to question 49 and the supplementaries to it. We now move on, Minister, to question number 39. It was asked by the Honourable Feni, and it relates to the health market inquiry. If we can have your response, please, Minister.
Yeah, Honourable Member, back around about 2012, we're worried about the escalating cost of private healthcare. Everybody here knows about it, how expensive it is to go into private healthcare. It's very much worrying. And out of this worry, I personally approached the Competition Commission because I was told that one of the contributing factors is a ruling made by the Competition Commission in 2006, whereby when people in the private healthcare sector, they used to sit together under a structure called REMS to negotiate on prices of everything, from a price of Panado up to brain surgery. They will negotiate them. And the Competition Commission banned that. They said that is price fixing. Unfortunately, when that went, the prices started escalating. It was one of the factors. But the Competition Commission said I was actually using anecdotes. They said they wanted scientific evidence that indeed their ruling is the one that mainly caused the price to escalate. But eventually they agreed to compromise. They said, let's put a public market inquiry to do a market-wide investigation about this cost. And that committee was put up and chaired by former Chief Justice Ngobo with other 4 people. We thought they would take 6 months. The work became so big that actually it took 6 years to finalize that work because we had even people from the other countries, the OECD, World Health Organization coming to present, and people from our own private sector presenting, and it became more complex. But at any rate, that work was finished after 6 years, and their findings are numerous. One of them is that they found that private healthcare in South Africa is characterized by high and rising costs, as we said, in a predominantly fee-for-service market. Fee-for-service meaning we are paying cash for health. Quite a number of people do so. And I want to inform you that that's a phenomenon that is prevalent on the African continent. Don't think other countries are doing that. So that was found. And among the recommendations that are numerous is that private healthcare needs to be regulated. It can't just be left on its own. We have been trying as government to regulate it, but we met a lot of headwinds when we try to regulate. The only structure that is in private healthcare that is regulated by an act of parliament, medical aids, even though they get out of control, but at least there is a measure of regulation because we have got the Medical Schemes Act, which was passed in 1967 and amended in 1998, at least that will tell medical aids, don't do this, don't do that. But there is no single act of parliament that regulates what must happen in a private hospital as to what they must do and what they must not do. And as I said, we've been trying to do that, and there've been a lot of court cases, there've been a lot of, fight back and all that. But Chief Justice Ngobo found all those. And among the recommendation is that we need to put up a structure that will regulate what must happen in private healthcare. The other recommendation, which I'm sure is going to shock South Africans because we are not used to that, is that we must find a way to do away with paying cash for healthcare. They say it's a very serious, perverse incentive that causes over-servicing, that nobody ought to go to any doctor or any hospital or any institution where they must receive health and produce cash to pay for that. That's why we came up with this concept of NHI, on which we are still battling to understand each other. But those were the findings and those were the recommendations. So many people in the private health sector were applying to the Competition Commission as individuals, asking to be freed from this ruling of 2006. The Minister of DTIC refused, but on the 14th of February, he gave a block exemption rather than exemption to each and every individual, so that they can sit together to start negotiating the prices following the health market inquiry said. Thank you very much.
Honorable Feni, do you have a follow-up question?
Thank you, Honorable Chairperson. Thank you once more, Honorable Minister, for your elaborate response to my question. The question is, how will the recommendations made by the Health Market Inquiry regarding private healthcare will influence the process of implementation of the NHI?
Thank you, Honorable Feni. Back to you, Minister.
Some of the recommendations, remember that these recommendations were finalized after 6 years of investigation, and it was in 2019, when the Department of Health studied them to try and put over regulations to implement them. COVID struck and everything stopped. There was no chance where it will make sense for the department to be talking about market inquiry in private healthcare when we're faced with that big epidemic, if you know what was happening during COVID. So they were shelved. And after COVID, when the department restarted, the sixth parliament was dissolved and we went to the seventh one. It's only now that we've finished. Now, we have also produced regulations for NHI. We are trying to integrate them because when the market inquiry was concluded, we did not have the act. The act was not yet passed. And some of their recommendations, they say, in transition, waiting for NHI, while you are going to do this, this is what you must do in the meantime. And we are following that already. And so where we can, we put a regulation in terms of the market inquiry. Where we think it's unnecessary, we refer to the new provisions in the NHI Act. Thank you.
Thank you, Minister. The next supplementary question will be posed by the Honourable Machobeni.
Thank you very much, Chair. Good day, Minister and the members. As your response, Minister, concerning EE recommendation, the Health Market Inquiry spent 5 years investigating the private healthcare market and published its final report way back in September 2019. Yet to date, those recommendations have still not been implemented. What step have you taken to implement a recommendation? Why has been delays in implementation of recommendations, and which timeframes have been put in place in implementing all recommendations? As you said, Minister, it needs to be regulated. I just want to understand when. Thank you very much.
Thank you, Minister. If you can reply to Honourable Machobeni.
Well, Honorable Member, it is true that the final report was issued in September 2019, and I've just informed you. The department then sat down, it's quite a thick booklet, to study it and see what you can do. And 5 months later, we're overtaken by COVID. The country was under that pandemic, as you know, and that work stopped altogether. True that they completely stopped it and just took the report and shelved it. And thereafter, after COVID, we started from the beginning, and we had to negotiate with the minister of DTIC. Eventually, that work was done, and on the 14th of February, the minister gazetted a law that gives a blanket exemption to all the people in the private healthcare sector. Remember, one of the mistakes that people like committing is to believe that private healthcare sector is one homogeneous group with common interest. It's not true. It's not true. Private healthcare have got many segments, some of whom working against each other. That's why they have to negotiate. If you are an executive of a medical scheme, you are not necessarily good friends with somebody who owns a private hospital because you don't want them to charge you a lot of money. You like to sit with them, well, of course, in a collegial manner to negotiate, which is what was abolished by the Competition Commission back in 2006. So that has been brought to the fore. That's why in February, in a joint press conference with the Minister of DTIC and the Competition Commission held at OR Tambo Airport, we now released this recommendation publicly and announced what is going to be implemented. And that program has started. We have got to start by putting up committees, by looking at which one is easier, by looking at which one is short-term, which one is long-term. But that work has started because we released the recommendations publicly. Thank you very much.
Opportunity now passes to Honourable Godsell for a follow-up.
Thank you, Chair. Minister, the Health Market Inquiry Report recommended a holistic structural reform. So why then did you and your colleague, the Minister of Trade, Industry and Competition, decide that regulations, rather than this holistic structural reform, was the appropriate route for the collective determination of tariffs for healthcare services, diagnosis and treatment codes, and quality metrics?
Well, I'm not sure what you mean by comprehensive regulations. What we know is that the Health Market Inquiry recommended that we establish a 3A government entity to do that work we're talking about. A 3A government entity under the Public Finance Management Act. It's not us in health and my colleagues who resisted that. Treasury told us 3A, that they will never accept that because they said there are too many 3A entities in the state and they are in the process of cutting them down. Some of the recommendations to cut them down come from this parliament about the number of SOEs all over the country, the number of 3A entities. And they said, no, we're not going to agree to put a 3A entity. It's going to be...
Apologies, Minister. Please, members online, please mute yourselves. Ensure you stay muted. Thank you, Minister. Apologies for the interruption.
Yeah, they argued that it's just going to be more expensive than it is at the moment. And we've got a reference point. As I'm speaking to you now, at the present moment, the amount of money used in private healthcare for the administration of the system is already 22 billion rand, just for administration. That money doesn't go to help any patient whatsoever. It just administers the system. It pays for CEOs of medical aid schemes. It pays for trustees of medical aids. It pays for data capturers, for clerks, and all that is 22 million. Compare that with the amount of money that is received by doctors, GPs, those who are in GP practices, all over the country, whether in the townships and in villages, they are getting only 11 billion rand. So the worry is, do we spend more money administering healthcare than spend more money treating patients with that money. That money must go into patients or into the pockets of those who are delivering healthcare, not in the pockets of those who are administering. So it is because of that reason that Treasury did not agree with this new 3A entity, which will create more salaries and all that. It is members in this house who complain about the bloated public service. Now we're about to choose a new entity with CEOs and directors and all that, just to make sure that they regulate private healthcare. So we're going to move into reverse. On that grounds, Treasury did not agree with the health market inquiry. Thank you.
Thanks, Minister. We now recognize Honourable Mokwele for a supplementary question.
Thanks very much, Chair. And thanks very much, Minister, for your response. In the main, you nearly respond the question that I'm going to ask you. But, Minister, there are civil society organizations, those that they threaten to take your department to court in implementing the NHI. So I just want to check with you, Minister, that how can you respond to those that in the main they are citing the reason that can't afford and stuff like that. So I just want to check with you, Minister, that how can you respond to those that they are threatening you to court to say that this thing is not implementable, citing the reason that we can't even afford it as South Africa? I thank you, Minister.
Thank you, Honourable Mokwele. Back to you, Minister.
Well, it's part of our democracy for people to rush to court. Don't be surprised. At the moment, there are 4 cases in court. One is a case against the department by Solidarity. The second case is by BHF, or Board of Healthcare Funders, which is an association of medical schemes, understandable. The third case is by a specialist association. Some specialists came together to form a structure called SAPFF. And it's not surprising to us. I gave you the figures of what is spent in healthcare. And I told you that 22 billion goes to the administration of the system. 59 billion goes to specialists, but GPs get only 11 billion. And they are numerous, if you know, in every township and in every village. So it's not surprising who's going to court and for what reason. We responded to Solidarity. Sorry, I forgot the third one, the fourth one that came recently is by HASA, Hospital Association of South Africa. We responded to Solidarity with a 216-page affidavit. I'll really ask you, honorable members, to go and read that affidavit. The affidavits you see in newspapers all the time are the affidavits of those who are opposing NHI. When we respond and write our affidavits and answers, it's never published anywhere. I can assure you, we can go and check in all these newspapers. They want to believe that they are ravishing us. There is this issue of cost that is not affordable. And every time they quote a figure of 1.3 trillion, which is more or less the budget of the whole country, and say NHI is going to cost 1.3 trillion. That figure came from Momentum Life. And I issued a statement for which they came back and say I was very harsh. Maybe I was. I said that was mathematical hooliganism, what had happened. Because what happened is what they did, and they came to me and said, no, it's not us, it's the newspapers. We were in our workshop. We were putting, that's the explanation they gave me. We're putting several proposals of what's likely to happen. And one of them, which will never happen, I can tell you it will never happen, because it has never happened anywhere in the world, is to assume that every South African will only use a private hospital. What am I going to do with all these big public hospitals that are there? What do I do with Groote? It's the only public hospital that can do a heart transplant. Should we close that? In the private sector, there are only 2 that can do heart transplant. It's the Christian Barnard Memorial Hospital here in Cape Town and Mill Park Clinic in Johannesburg. Where will people go if we close Groteskiri? Where will people go if we close Steve Biko? The only alpha target in nuclear medicine in the whole country is happening in Steve Biko. Even private hospital refer people there. Now, here is a proposal that everybody must use private hospital. And after that proposal, they then said, how much do private hospitals charge? They took that number and multiplied by 63 million people and say, this is what NHI will cost. That's not NHI. It's not going to work like that. It's not in any act. But they keep on repeating it. And the people who did that said no. I asked them, why didn't you issue a statement that you are being misunderstood? They said we have issued it. All the newspapers refused to publish it. Because the only thing that gets published is something that is negative about NHI. Thank you.
Thank you very much, Honourable Minister. Now that brings us close to question number 39. We now move to question number 36 that was asked by the Honourable Aris. Honourable Minister, your response to that question.
Yeah, this question, I've answered part of it. It's about medicating factors, about PEPFAR. I've already explained part of it, what PEPFAR is funding and what's not funding. But one of the measures we have taken, honorable members, to avoid HIV-related death, number one, we took a decision that regardless of this PEPFAR problem, not a single South African must be deprived of ARVs. Those who were on ARVs, not a single one must wake up and say, today I went to collect my ARVs, I couldn't find them. We took that decision. Secondly, we said not a single South African who tests today and find themselves positive must not be deprived of ARVs, whereby they will say, I tested positive, but I could not find ARVs at clinic. We took that decision. And how did we do that? We called several workshops and meetings and issued a circular where we advised provinces to redeploy trained department health official staff to fill the gaps that were left by PAPA, to do task shifting, to provide enrollment of patients on repeat prescriptions, to do what I mentioned earlier, 3 MMD, that let people collect their treatment for 3 months and not come to healthcare all the time. We are now busy with 6 MMP to provide 3 months pre-exposure prophylaxis dispensation for all clients who are on PrEP, implementing a 28-day late collection allowance. In the CCMD I told you, where I said more than 3.3 million people no longer go to clinics. They just go to the address they've provided where they collect their treatment. Now, the providers were told that if after 1 week this parcel is not collected, they must send it back. So we asked them to keep it for 28 days. That keep it there for 28 days until the owner comes. I told you about CCMD. So we have done quite a large number of things, but we are also meeting, we have also met with a lot of funders, and the discussions are still ongoing together with Treasury itself. But up to so far, we believe the measures we have taken will go a long way. And lastly, we said anybody who was attending a clinic that was funded by PEPFAR, if it is closed, they must come back to the public health clinics and facilities, because we are providing people there. And as I'm telling you, we've got many more districts where we are providing this work. It won't be difficult to absorb some of the patients there. And we are busy doing that. We are in that process of absorbing them. And that's why at the present moment, we think up to so far, things are still going so well that even 21 days after this announcement was made, or more than 3 weeks after the announcement was made, we went to Johannesburg, Chris Hani, Baragwanath Hospital, and Lillian Goy Community Center, and launch the 1.1 million. We launch it and say, let's go to look for 1.1 million more people, knowing very well that PEPFAR have taken back their resources because we're confident that we can still do it. Thank you.
Thank you very much, Honorable Minister. Honorable Harris, you have a follow-up question. I don't see the Honorable Harris in the House. I don't know whether she's on virtual.
No, pardon, Chair.
Is Honorable Kennedy, are you taking the follow-up question?
No, it's taken by Honorable Kennedy.
Okay. Go ahead, Honorable Kennedy.
Thank you. Thank you, Minister, again. Minister, the ruling party has for years overly relied on foreign aid. The consequence of the over-reliance is now clear as the country now faces a public health crisis that is not financially prepared to handle on its own. What measures have you put in place to ensure that the state takes full responsibility in ensuring that all South Africans have access to quality medical services? Thank you.
Thank you very much, Honorable Kennedy. Honorable Minister, your response.
At the present moment, this is what I said in the debate on this issue, called by your Commander-in-Chief, Honorable Member. There was a debate about this PEPFAR, and this is what I told him, that I'm challenging him to bring another debate, that in South Africa, we are spending 570 billion rand on healthcare. Because when the World Organization recommended, I've just given you a figure they recommended for mental health. For the overall healthcare in the whole world, they said if a country can spend 5% of its GDP on health, then the whole population will be covered. Now, 5% of GDP on health is a lot of money. We have long exceeded that in South Africa. We are not at 5% of the GDP. We are at 8.5%. That translates to 570 billion. The money we get from PEPFAR is only 8 billion. But here is a country that is spending 570 billion already, and we go and chase somebody and beg them for 8 billion. What is our problem? Our problem is the manner in which that money is distributed. This gross inequality in our country. And how is it distributed? That 570 billion, 51% of it goes to support only 14% of the population. And who is that 14% of the population? Is me and you. Everybody who is on medical aid. We are spending that 51% of the GDP on them. The remaining 49% must be distributed among 86% of the population. That is our problem. And how is that money spent? Just to give you an example, look at HIV and AIDS. The 5.5 million people who are on ARVs, only 6% of them get this money, which is 51% of the total expenditure. Let us look at TB. Nobody using that money in private health care treats TB. Is treated by this money, which is in the 86% of the population. It is untenable. It's gross inequality that we are faced with. If we end the gross inequality and have a fund that supports everybody, regardless of their socioeconomic status, we will be able to make it. And it's not something that is new. When we launched the HIV/AIDS program in 2010, one of the reasons that we have been so successful, and we are not just praising ourselves. Since we launched that program, we have reduced death from HIV by 51%. We have dramatically reduced maternal mortality. Women who were dying in pregnancy and childbirth because they were killed by HIV. How were we successful? Because we made one rule, that it doesn't matter whether you are a millionaire, a billionaire, a domestic worker, a gardener, or you are living on the streets. If you test positive, we treat you. and that money must come to the state. We've said so in HIV and AIDS. What makes it impossible in all the other diseases? Basically, that's what we want to do. Once we do that, we don't have to depend on anybody. Thank you, Honorable Member.
Thank you, Honorable Minister. We now go on to the follow-up question from the Honorable Swat.
Thank you, Honourable Chair, and good afternoon, Minister. Minister, I'm a bit, I've listened to you now twice in this today, what you explained about the PEPFAR and the impact on South Africa. Listened to a lot of people, read the news, CTV, the value of the PEPFAR contribution. That fell away, and the impact on the short term on the lives in South Africa. Now, what I've read in what you've explained today to us here is that the withdrawal of this money, South Africans, don't worry, it's not a train smash for South Africa. That is how I read you. Because we pay a lot or the most of the programs, but the money is not only in what the contribution from PEPFAR is not only for the treatment, but also for the value, the research that was done in South Africa. And the question also, because that is the first part of my question that you've answered, but I really need clarity on what you said on the impact of the withdrawal. And the second one is, what measures has the department put in place to ensure that the withdrawal of PEPFAR funding does not negatively impact the LGBTQIA plus community, particularly in terms of access to treatment and especially discrimination in health care issues or service? How will the department safeguard against the stigma and ensure that this vulnerable group continues to receive necessary support?
Thank you very much, Honourable Member. Your time has expired.
Mr. Chair.
Honourable Minister, your response.
Honourable Member, the withdrawal of PEPFAR is definitely a train smash for people who are employed. The 15,315 or so people who have been drawing salaries from this, they are unemployed. That's a train smash for them. We accept that. We're not hiding that. That's why we have already met so many funders. We are having meetings every day about that because we feel bad for these people who have lost their jobs. What I was talking about, I said, however, they believe that it will stop our people from continuing to get ARVs. We have tried to mitigate against that. That's what I'm saying. Because in the first place, we're not using this money to buy ARVs. We're buying them on our own. And we're also helped by the Global Fund. And the Global Fund gets its money by doing what they call a replenishment round, whereby they choose one country every 3 years to meet there and call all the countries in the world and call all the other funders and philanthropists to put money for Global Fund, and that money is distributed in terms of which country carries the biggest burden, which means South Africa is one of the biggest beneficiaries. Coincidentally, for 20 years, the Global Fund has never come to Africa. And for the first time in 20 years, they are coming to do that replenishment round here in South Africa, which is going to be in September this year, which is being hosted by President Ramaphosa and the President of the UK, Keir Starmer. Together, they are going to come together to host this and call all the people. And we are already in discussions with them how they are going to replace this. So much as you can't say any cent that is taken away doesn't shake you, we just want to reassure our people that the treatment goes on. That's why we never stop this issue of 1.1 million people. So the issue of research, it is, of course, a setback. There's no question about it. But it's not only a setback for us, I can assure you. It's also a setback for the US, unfortunately, And these days, they get angry and fire people. I hope they don't fire me from South Africa for saying what I'm going to say. Part of the research was not benefiting us only. It was sent back to the US, where many pharmaceutical companies will know what product to produce out of, because remember, we are the ones who are carrying the people with the biggest diseases. So that the vaccines and all that all come from there, out of research done here. So this research is lost not only to us, to the whole world. We accept that. But we are saying, as far as the program of putting people on ARVs to reach our 95, 95, 95, we try by all means, it doesn't stop. The LGBTQW plus, which you are talking about, we are asking our hospitals and clinics. I'm sorry, I might have made a mistake when you mentioning so many, what you call, at the same time. Sorry, I withdraw that. Thanks for your correction. But we said they must find space in our own public health institutions and try by all means that we fight the issue of stigma, because I don't want to believe that the only one way stigma can go away is when there's PEPFAR. We can also do it as South Africans on our own so that we are less dependent on foreign funding. Thank you.
Thank you, Honourable Minister. The next follow-up question is from the Honourable van den Berg.
Thank you, Chair. Minister, to a certain extent, you did answer a bit of my question, but mine is different. So I'm going to ask you, I'm going to still ask you this question. So given the loss of funding from the US, our second biggest trading partner and previously biggest public health benefactor, due to issues in international relations, why are the other trading partners like China, Iran, and other BRICS countries not taking up the shortfall created by the US? And if they do or not, what financial commitments are we getting from these other countries regarding our HIV management strategy? Thank you.
Thank you, Honourable Member. Honourable Minister, your response, please.
We have met quite a number of countries, and I'm not going to disclose here before the finality. We have met quite a number of funders. Very early on, after this announcement was made, the Clinton Health Access Initiative, which is called SHI in short, coordinated funders. We met the Elmer Foundation, we met the Bill Gates Foundation, large number of funders, we discussed this issue. We even met countries who came to here. All of them said, we understand you, we'll come back to you. And I made the statement in the National Assembly that we must also accept there's no country anywhere in the world, there's no funder anywhere in the world who had a pot of money put somewhere as a spare, waiting for an explosion to come back, to come out of the state. They were not ready for that. So they are still going back to rearrange their things before they can come in. Remember, PEPFAR have been on this for the past 20 years. They've been funding the world for the past 20 years. So every year they knew what amount of money. These other countries never did that. It's only now that they are going to start and doubling up. And that's why I even mentioned the Global Fund, to which we also contribute, by the way. In the last round of the Global Fund, South Africa contributed 13 billion, 13 million US dollars, not billion, we don't have that amount of money, but we contributed. So every country, regardless of how little is it, it contributes. So at the moment, we can't really believe countries must rush in to fill up the space. It's something that they had never prepared for, something that is new, something that has surprised everybody. Big and small countries are alike, so we would like to give them a chance and see. For instance, we would like to see what they are going to do in September when the replenishment round is here. Because in the replenishment band of Global Fund, you contribute according to your ability. And the money is distributed according to the needs of those particular people. So it's too early to make a conclusion that people have not come to the party. They may still come. Thank you.
Thank you, Honorable Minister. We now go to the next follow-up question, which is from the Honorable Sibande.
Ngiyabonga Minister. Minister ngeke saliwa ukuthi bakhona osiphunduka ubuni abaphokophele ukudicilela phansi isithunzi senhlangano kanye nohulumende obusayo. Ngaloko umbuzo wami uzothi ke will the deployment of the staff to fill gaps left by the PEPFAR not affect the areas where they were initially deployed? Well, thank you.
Thank you, Honorable Member. Honorable Minister, your response.
Well, that's why we spoke on task shifting. They must sit together. You know, this formula, this circular we have sent around, that people must do task shifting. And it's true, that is going to be a little bit more of work. But let me tell you our analysis of the PEPFAR funding. It is top heavy on administration also, as is the American healthcare system. It's very top heavy. So we are calculating, for instance, how many people are patient facing out of this 15,000. How many people wake up and face a patient every day? And we found that there are only 8,000. And they are not any huge amounts of money. The huge amounts of money are those top administrators at the office. We are making an analysis on all this. We are sharing it with our funders. We are sharing it with the Treasury. And we still believe up to so far, we can hold on, and we've been able to hold on up to so far. It's possible that later on, it may become very heavy on us. But at the moment, we're still holding on. Thank you.
Thank you very much, Honorable Minister. That concludes question number 36. So we'll now move on to question number 34 that deals with the impact of medicine shortages. It was a question that was asked by the Honorable Mokoena. Honorable Minister, your response, please.
The issue of how we address the medicine shortages, especially in KwaZulu-Natal, the KwaZulu-Natal province has implemented the following mechanisms for managing stock out and shortages of medicine at facilities. One, they've increased facility monitoring and support visits with an emphasis on monitoring the availability of medicines and consumables. Because some of the shortages is not because there's nothing in the stock at office. It simply means in that particular clinic, they did not monitor the stock and be able to order on time. They are also convening weekly meetings between provincial managers and district managers to follow up on matters concerning the availability of medicines and consumables. Again, these weekly meetings are meant to catch immediately whether that there's no stock out. The redistribution of stock between facilities to assist those with low stock or stock outs of items, because sometimes there are facilities that have run so low when the others are running very high and they can share. The processing of emergency orders for critical items is fast-tracked. Moving of funds, that means what we call virements, to cover facilities, especially clinics that have run out of budget. The consolidation of supply needs allows the bulk orders to be placed with funds pooled from various facilities for efficiency. The convening of meetings with suppliers management to discuss payment plans, which have led to the lifting of account credit blocks. Because sometimes we say there's a drug stock out because the supplier refused to supply because they were not paid. So we are checking all this. Escalation of supply constraints in the national department. When suppliers indicate an inability to supply, the matter is escalated to a contract management unit at the National Department of Health, where necessary therapeutic alternatives are recommended. The National Department of Health also facilitates the authorization of unregistered product using authorization from South African Health Products Regulatory Authority in terms of Section 21 of the Medicines and Related Substances Act, meaning the ordering of medicines that are not registered, but which are needed by patients where they can't find them in any clinic. You go to SAPRA and via Section 21, you can be allowed to order that unregistered medicine. Support is always provided for healthcare workers. Ongoing facility monitoring and support visits are conducted. Weekly meetings, as I've said. Medicine information is provided by healthcare workers during their consultation with patients. The MEC for Health has communicated and continues to communicate on matters regarding availability of medicine and importance of remaining on treatment for chronic conditions. The department's communication unit ensures that these messages are available across all the media platforms, especially social media. There is a widespread communication at facilities advising the public to report any shortages of medication to facility managers. If they are not fully satisfied with the service at the facility, patients are encouraged to escalate their concerns or complaints to provincial management via the toll-free number 0800 005 133 or on WhatsApp at 082 314 1167. I want to repeat the toll-free number which we want all patients to phone because it's toll-free is 0800 005 133 or they can WhatsApp 082 314 1167. Thank you very much.
Thank you very much, Honourable Minister. Honourable Mokoena, you have a follow-up question.
Thank you, Minister. My follow-up question, Minister, is with regards to the MEC of Health in KZN, Ms. Honourable Nomagugu Smelane. I can assure you, Minister, that there is a serious shortage of medicine in hospitals and in clinics in KZN. In fact, there's one particular case of a patient who went to the KwaMashu healthcare facility and was actually told to go and seek his chronic medication somewhere else. In fact, it's led to the PSA, which is a Public Servants Association, to write to the Human Rights Commission as well as the Public Protector, because the communications department within the KZN Health has not done its job. What is the Minister doing to ensure that the public gains trust in the department and that there's transparency in terms of information processing? Thank you.
Thank you very much, Honourable Mokoena. Honourable Minister, your response, please.
Honourable Member, the way I listen to you, you are giving one specific example that happened in KwaMashu or somewhere. I won't know the facts under that. Please bring them to me. I'm happy that it has gone to Human Rights Commission and the Public Protector. But these are examples that you are giving. Please give them to us. But I want to tell you this about this issue of drug stock out, which happened some years ago, and I'm telling you the truth. That's why I want us to be brought here to investigate. There was a lady, this time it was not in KwaMashu, not a lady, a gentleman. It was not in KwaMashu, it was in Gungundlovu, who appeared on TV crying that she's HIV positive. There are no drugs in the hospitals. There's in the clinic where she collects, the drug stock out and all that. And the TV station was on our case, hitting us very hard. Fortunately, the people in Gungundlovu recognized that lady. And they found that, that gentleman. And they found that he's on CCMDD. He doesn't depend on a clinic to receive ARVs. They are supplied to that person. And the suppliers, we have asked them that they must produce a receipt. After delivering, they produce a receipt which is signed that I've received, just like you receive any packet. And the supplier was able to produce that. Last week, I went to deliver ARVs to this person. This person doesn't need to go to a clinic. And so we confronted, but why did you do that? And we discovered that he was encouraged by an NGO to go and do that, because sometimes we fight for money and you want to show the state that if you don't give me money, this problem is going to escalate. So we want to investigate each and every case, because here is a person who received ARVs, signed for them, and rushed to TV to cry that she's going to die, is going to die because there are no ARVs. So we want to be, it's not in our interest, by the way, that drugs must run out, especially ARVs. It's not in our interest, because it's not even in the interest of the whole world. If you run out of ARVs, you develop resistance. And when you develop resistance, two things will happen. We will need more expensive drugs to treat you when you come back. And the second thing, you will spread a drug-resistant disease. It will spread in the country, in your community, and all over the world, and the world won't be able to treat it. So it's not in anybody's interest. That's why we are giving you these numbers, that please try to help. If somebody has lied, in the clinics, some years back, it's only that I didn't investigate. We even gave nurses, we even gave them cell phones, whereby they were able to manage the stock. You know, there was an app on the cell phone where because as I'm telling you, as I'm standing here in front of you, we have got what we call a buffer stock in Pretoria. We don't rely on ARVs in the hospital and clinic. There's a buffer stock that is waiting for that moment when there's an emergency. And when there is, we release the buffer stock. Up to so far, we never had to release it because it's just the manner in which drugs are managed. We release the buffer stock if there's a shortage in the world or if there's an emergency that was unforeseen. That buffer stock is still there, very intact. Thank you.
Thank you very much, Honourable Minister. The next follow-up question is from the Honourable Mokwele.
Thanks very much, Chair, and thank you, Minister, for your response. I also want to agree with you that indeed the department is managing the shortage of staff. It is also encouraging, Minister, to note that the government is managing the issue of medicine shortage in the provinces. I can attest to that, Minister, because the same day when you were in Gauteng at Liengoi, as the Select Committee on Health, we were also in Gauteng doing oversight. We visited a number of health facilities there, where we even went to a place called the Lopia Clinic in Hammarskraal, where we witnessed that. But Minister, my question to you is that there is this thing of budget cuts that we are currently facing. I want to ask to you that what role does this budget cut play in the availability of medicines in the health sectors? I thank you.
Over to you, Minister.
Yeah, it's not only availability of medicine where we're affected with budget cuts. Last week, we submitted even to the president the accruals that are there in province. There's not a single province out of the whole 9 which does not have accruals. 9 out of 9 have. And if you listen to the Minister of Finance budget speech in the National Assembly, he mentioned this problem, why he's trying to reverse this, which happened over a period of 10 years because of austerity. He said something that he doesn't want austerity because he wants to solve this problem, that all provinces towards this time of the year, they are no longer able to pay. They wait for new money, and that new money is paying for last year's debt, meaning they're starting a new debt now. Now, quite a number of people believe this debt is only on medicine. No, it's also on 4 very, very important things. Oxygen supply, which we get from AFROX. Blood supply, which we get from South African Blood Transfusion Services. NHLS, where the tests are done. SANMED, where we receive equipment. All of them are very important stakeholders which don't get paid when we've got accruals. And we've been making noise about this issue, that the accruals that are accumulating in health are going to drown the healthcare system of the country. Now, the minister gave us 29 billion rand over the next 3 years. We're sitting yesterday to see what we can do with that money. Having had budget cuts for the past 10 years, it's not easy that in 1 year we are going to solve this problem. I just said it's a good start. It's the beginning of reversing the trend that has happened over 10 years period. And we are going to try our best to see what can we do with the little we have. Thank you.
Thank you, Honorable Minister. The next question, follow-up question will come from Honorable Pinar from Limpopo.
Goeiemôre, agbare Minister. Minister, the Department of Health is still struggling to ensure the supply of critical medicines to vulnerable individuals, given that you have led the ministry for over a decade, yet you can still not guarantee the most basic of services? How do you expect to successfully implement the ANC proposed NHI when you cannot even oversee medicine supply shortages? Thank you, Chairperson.
What do you, Minister? That question is always asked all the time. All the time. And then I tend to understand the misunderstanding of what NHI is. People believe NHI is a vintage program, which you can only implement if you have been able to solve all the problems in the world. They believe it's a Porsche, that you are very rich and you have done everything and now you have got spare money to buy this Porsche. That's not NHI. NHI is not only stemming from us, it's from the World Health Organization. And part of the reason why they came with it is that out of the 6 building blocks of healthcare financing, they found that one of the building blocks, which is healthcare financing system, the 6 building blocks of healthcare, one of them is healthcare financing. They found that in the world it's always skewed towards the rich. When it gets skewed towards the rich, you experience all these problems. That on the side where the poor receive their treatment, there is shortage of staff, there is poor management, there is shortage of medicine, there's no infrastructure. So the NHI is to equalize. That's why the former Director General of the World Health Organization said it's an equalizer between the rich and the poor. That's the reason why you are implementing NHI. That's why when you check its history, you will find that every country that has implemented it, they never did so because they've solved all their problems. They did so because they had problems. Let's start with the UK in 1948. Why did the UK have NHS in 1948? Why did Canada start it in 1947? All of them were responding to the Second World War, the crisis brought by Second World War, whereby Hitler was sitting on the UK all the time. At the end of the war in 1945, they were poor, they were unemployed, they were sick, and they said they want to rebuild their economy. And the UK was told, no one rebuilds the economy with sick people. You can't. Start a system that provides healthcare to everybody on the equitable basis. Then you'll be able to build your economy. We are faced with that situation here. And I tell those people in the private sector who believe we are going to collapse the healthcare system, believe you me, if in 2010 we did not launch the world's biggest antiretroviral treatment, many companies will have collapsed. The economy of South Africa will have collapsed completely because, honorable members, let's remember how many times we used to go to graveyards before 2010. How many times we used to go even during the week. How many people were burying. How many teachers were absent from schools. How many people were absent from the mines and factories of this country because they were on the bed and they were HIV positive. Today, that's no longer happening. That is what collapsed the economy. And I told you how we ran that program. We said anybody, regardless of their socioeconomic status, must get this ARVs free. We said so. Whether you are a billionaire, whether you are a pauper, whether you are a domestic worker or what, you are entitled to get that treatment. And we believe when that happens, then you have solved a problem with healthcare financing. Now, people believe it's the other way, that solve all the problems first. When there are no more problems, you implement NHI. And I'm here to tell you, if we can solve all the problems without NHI, then we don't need it. There's no reason that we must chase it because we'll have solved all our problems. Thank you, Honorable Minister. I think the explanation was very clear. The next follow-up question is coming from Honorable Suisa, the delegate from Northern Cape.
Thank you, Chair. Thank you, Minister. Minister, the case of Kwamashu, it's one too many. It needs to be resolved. And you also need to look into the issue of NGOs that are trying to compete and connive with our people for the little resources. But it's not here, not there. KZN Department of Health has failed to respond to the South African Human Rights Commission on the matter concerning the medicinal shortage in KZN and has instead requested an extension. What are the reasons behind the request? That request an extension, and how is the ministry intervening in the matter from a proactive approach? Thank you.
What to you, Minister? Well, time and again, entities do ask for an extension, whether from the Human Rights Commission, the Public Protector, or even in the courts of law. You ask for an extension if you have not yet finished your work. Even here in Parliament, sometimes when we have asked questions, when we go to get information from somewhere, we are not able to answer on time. So I may not know, and I do not know, why KZN has asked for an extension. If the Human Rights Commission wants to escalate the matter to us, we'll know, but up to so far, they haven't done so. And I won't know any good reason why they asked for an extension. It's possible that they were still gathering some information somewhere. I'll go and investigate that, honorable member, because I didn't know. Thank you very much.
Thank you, Honorable Minister. We're now going to question number 40, asked by Ms. Baines from the Western Cape, but the stand-in is Honorable Sibande from Mpumalanga. Over to you, Minister. That one of foot and mouth.
Very much, honorable member. South Africa is responding to the outbreak of hand, foot and mouth disease in KwaZulu-Natal and Eastern Cape provinces. The province of KwaZulu-Natal started notifying confirmed cases in January 2025, while the notification from Eastern Cape started in February 2025. As of 12 March 2025, a total, that means as of this month, a total of 745 cases were confirmed in South Africa. KwaZulu-Natal and Eastern Cape had confirmed 667 of the cases, 667 rather from KZN and 78 from Eastern Cape, sorry. A total of 11 districts are affected. In KwaZulu-Natal, eThekwini Metro has got the majority of cases. Other affected districts are King Cetshwayo, Ugu, Mgongundlovu, Zululand, Ilembe, Utukela, Mkhanyakude, Herigwala, and Umzinyati. The Eastern Cape has reported cases from Buffalo City. Most of the cases have been reported in both primary schools and early childhood development. No deaths have been reported. Honorable member, this is a very mild disease. It does not usually produce any fatalities. The 36 HMD patients were admitted, and these patients were not severe, even though they were admitted. They were fed intravenously, reason being that you get blisters in the mouth. You are unable to eat. You can be walking around and running around, but simply because there are blisters in your mouth, you may not be able to eat. That's the reason why they were admitted, not because the disease was very severe. Now, there is a question about the relationship because it confuses people. Foot and mouth in agriculture, hand, foot and mouth in children. Honorable members, there is absolutely no relationship. Absolutely not. There is no way in which they are related. Foot and mouth disease in agriculture in animals affect only cloven-hoofed animals. Not all animals are affected by foot and mouth. Cloven-hoofed meaning animals which have got a cleft, a space in their hoof, like cattle, goats, pigs, etc. For instance, foot and mouth, it don't affect a horse. The hoof of a horse doesn't have a cleft. You know, it's one continuous thing. It don't affect zebras, etc. In the wild, for instance, it will affect buffaloes, but buffaloes are carriers. They never get sick. In fact, most of our cattle are infected by buffaloes. That is foot and mouth in animals. Whereas the hand, foot, and mouth in children is caused by a completely different virus, which is called the Coxsackie virus. The only reason that their name seems to be the same is because the vesicles that we develop are in the hand, in the mouth, and on the foot of children, in the soles of children. In the animals, it's the hind legs and the forelegs, but animals have no hands. So we don't add the word hand, you know? Yes, we only add the word hand in human beings. But the viruses are totally different. Both diseases don't kill, actually. Even animals don't. I've never met an animal. I was once an ME of agriculture. I've never met an animal that died of foot and mouth. Why is it just a big thing? It kills trade. It's not fatal to human beings or animals. It's fatal to trade. Because once it's reported in your country, the other countries stop completely trading with you. They stop your meat export, they stop everything, and farmers suffer. Why do they do that if it's not a dangerous disease? Because in terms of business, your livestock must be active. When an animal has got foot and mouth, it stops feeding. Some of them stop producing milk. You know, they just become lethargic, and no farmer wants to farm with such type of animals. So when a country hears that we have got it, they say, hey, sorry, solve that problem first, then we'll buy from you, and they stop you. That's where the fatality is in. It's in business, not in clinical medicine, not in, and also foot and mouth disease in animal is not a zoonotic disease. It means it can't move from animals to human beings. It remains with the animals. Even if you eat that meat, it won't affect you because it's not a zoonotic. So we're dealing with two different diseases. It's just that they sound the same.
Thank you, Honorable Minister, for the good explanation. Over to you, Honorable Sibanda, for the follow-up question.
Thank you, Minister, for your response, which is very positive. Nevertheless, I wanted to ask a question. Is it encouraging? It is encouraging to note that the department is managing the small outbreak of hand, foot, and mouth diseases, and that there were no fatalities. Is there no vaccination available against the HFMD? Thank you.
What to you, Minister?
Well, up to so far, I do not know about it. And remember, I told you, this is a very mild disease. And when people go out looking for vaccines, which usually are very expensive, it's for diseases that are problematic. Children who suffer hand, foot, and mouth disease, most of the time they are playing. Only that they've got vesicles in the mouth that are very painful and they're unable to eat. So up to so far, if there's any vaccine, I don't want to lie to you. I'm not aware of it.
Thank you, Honorable Minister. The next follow-up question is coming from Honorable Farmer Delegate from the Western Cape.
Farmer.
Chairperson, thank you. Being a farmer, I am thoroughly covered by the minister's answers. Thank you. Thank you for the acknowledgement of the good responses of the minister. The next follow-up question is coming from Honorable Mashowin from the Eastern Cape.
Enkosi Chair, uMinister uyicacisile lento kakuhle kuba wena uyayazi. I-problem yethu ke Minister, xa kufika ezizifo vis-a-vis i-humans and i-animals, ziye zifike xa besicacisela abezempilo zisoyikisa. In a way that njengoba bendizawubuza umbuzo ubana abantwana ke ngoku njengoba kuthiwa maba-isolate for 7 days benesi sifo, zeziphi ii-measures onobancedisa ngazo ukuba bangashiyekeli ngemva ezifundweni zabo. I'm not saying uba assisteke ngento like into ezinjenge-mobile clinics ezizawuya kweza areas kuba sihlala kwi-rural areas. Ufumaniseke uba sifika kudala kwisebe lezempilo. Kulapho ke ndithi Minister uye waphendula ngoba nyhani siye soyikiswe njengoba uyicacisa uba ezi zifo asibulali, but xa sisiya kwisebe lezempilo uyifika umehluko ungabi ngulo usinika wona. Enkosi, Honorable Minister.
Over to you, Honorable Minister.
Yeah, you see, honorable members, the reason that kids get isolated is simply because it spreads very easily. And the reason that it affects kids more than us, you know, kids touch and play and all that. Adults don't do that. You can have that disease here among yourself. You'll hardly touch and play with the next person. So kids play, they hug each other. They've got love. We are the ones who have got hatred. Oh, you stay there, the other one sit there. You don't want to sit next to each other. Kids don't do that. And that's why they easily get infected. And that's why we isolate them. Secondly, just like animals, in animals where I said the problem is trade, is that kids are going to lose a lot of time when they've got this disease. They lose a lot of time sitting at home, being isolated because we don't want them to infect all the others. But in terms of the disease being dangerous, I can assure you, that's why we have got, as I said to you, 745 cases now, not a single death. But let's compare it with a disease called Mpox. Yes, Mpox have got very, very few people who suffer. I think it's 31 now. But the whole world knows about it. They've come here. They are busy organizing vaccines for us. They're helping with money and all that because it's a disease that can kill a number of people, especially those with a lowered immunity. So this one, it happens on a lower scale almost every year, just like you catch a flu every year. We even have a vaccine for flu because flu is even more dangerous than this one disease. So as I'm saying, it's very mild. Children run around. It's only that the vesicles are very painful, especially when the water comes out of the vesicle, they collapse. The vesicle collapse and there's water out, and the tongue is sort of raw. It becomes painful when they eat. But in terms of it being a serious disease, where somebody must rush and get medication, anyway, it has got no treatment for that matter. We don't give any medication, we treat for symptoms, the pain and the discomfort and all that. So we have tried our best to do screening and send information around. As I'm saying, the misfortune here is that people hear about foot and mouth in animals. Then they suddenly hear about hand, foot, and mouth in children, and they cry at the same time. I was an MEC for agriculture in Limpopo. We used to be attacked by foot and mouth because we are nearer to the Kruger National Park. When the buffalo came in touch with the cattle, we never used to get this hand, foot, and mouth in children. So at the moment, because they coincided in the country, that's basically what is scaring people, even though there is absolutely no relationship between the two diseases. Thank you.
Thank you, Honorable Minister. Now we're going to go to the last supplementary question. This is coming from Honorable Andrense from Mukoni-Bupirim. Over to you.
Thank you, Honorable Chairperson, Honorable Minister. Thank you. For a moment there, I was thinking we're in an agricultural debate, but luckily I know we're not. So, although this is a mild disease, it can develop into viral meningitis and encephalitis, if I'm correct. So, has any of the hospital admitted patients developed into that? Any of the cases developed into that? Then the second one is, we've had now a spread to Eastern Cape. So what measures have been put in place to stop the spread to other provinces using travel and population movement and migration as a guideline? And then the third question, how has the government enforced hygiene protocols in schools to prevent hand, foot, and mouth disease outbreaks and ensure schools do not become super spreaders, apart from just letting the kids stay at home for 7 days until the little outbreaks or spots disappear? What did you enforce in schools? Thank you.
Thank you, Honorable Andrense. Honorable Minister, you know that you are only obligated to answer one question, but she asked three, but you have the chance to articulate the policies of your department. Over to you, Minister.
Yeah, whenever we hear an outbreak somewhere, whether it's a school or crèche and all that, in 2 or even 1 child, we go and screen all of them to see which ones must be isolated, so that you isolate them to stay at home for 7 days or so, to avoid them getting in touch with other children and infecting them. That's what we do. We also ask them on simple health hygiene, which is the information that we have given out, like sneezing and coughing into a folded elbow. It's very difficult to teach children to do that, but we try. Wash hands after you cough or sneeze. Again, very difficult for children. Avoid touching your face. Having to tell a young child that don't touch your face. In fact, he's going to touch it because they are curious, but we try to do that. Wash your hands before you eat your meals. That is the job that parents must do, that no child must eat their meals without. Wash hands after using the bathroom. Avoid close contact with those that are ill. That's why we sort of isolate them. Clean and disinfect surfaces or objects that might have been exposed to the virus. On the issue of viral meningitis, etc., we have not had any up to so far. If we get that, it becomes a big, big crisis. Even the World Health Organization will come into it, because viral meningitis is a very, very life-threatening disease. But up to so far, we have never had any of that. Thank you very much. The last question, you said they asked me 3, is about, how do we stop it from spreading to other provinces? You remember during COVID, how we cut even travel between borders and, in different stages and all that. And people were still complaining, some took us to court. We are not about to do it with this disease, because it's not as dangerous as COVID. If we may then wake up and start putting laws that you are no longer allowed to travel between Western Cape and Eastern Cape. It won't make any sense. It will be like using a sledgehammer to kill a fly. So at the moment, we are still dealing with a fly, not really a very scary animal. Thank you.
Thank you. Thank you, Honorable Minister, for honoring your appointment to come and address us as the House. And then in the Honorable delegates, we have come to the end of the questions of the Minister of Health. I would like to thank the Honorable Minister for availing himself to answer the questions. Honorable delegates, that concludes the business of the day. The House is adjourned. Thank you.
Long live the chair. Recording stopped.